Ladies and gentlemen, welcome to the Lake Superior Quality Innovation Network and the Michigan Community Health Workers Alliance Depression and Chronic Conditions, Why Does This Matter webinar. Your host for today, Mark Lausch, will now begin.
Hey, good morning, everybody. This is Mark Lausch, and I'm with Andrea Boucher, and we're going to be your presenters today for this sort of conjoined presentation of the Lake Superior Quality Innovation Network and the Michigan Community Health Workers Alliance. On our topic, depression and chronic conditions, why does this matter? First of all, I want to thank John Briles of Molina Healthcare for assistance with the concept and materials of this presentation, and also Priscilla Holman, Executive Director of the Michigan Community Health Workers Alliance, who approached us about doing a webinar that was geared toward community health workers. We're very happy to be presenting today. We are offering one continuing education credit for nursing and social work. Application has been made through CE through the Ohio Nurses Association and the Michigan National Association of Social Workers. So social workers in other states than Michigan will receive the social work certificate, which should be applicable in your specific state depending on the rules and regulations pertinent to that state. So that will be up to the individual to determine if they're going to use this as a CE for their specific state other than Michigan. For disciplines other than social work or nursing, participants will receive a certificate of attendance. And I'll give you full information on the how to apply for continuing education at the end of the presentation. So for our objectives today, we'll get right into the meat and potatoes. Our objectives today are listed on the slide here. So we're going to look at the importance of recognizing and addressing depression in patients with chronic disease. And we're going to look at how we're going to look at the prevalence of depression in diabetes and cardiac disease. Discuss the overall disease burden and the cost of healthcare in patients with these chronic conditions, depression and other chronic diseases, and we're going to discuss some interventions that have been shown to be helpful in addressing depression in patients with chronic disease. So, why is this important? So, the reasons why this is important are on the slide here. The disease burden of coping with chronic illnesses, sometimes multiple chronic illness, can exacerbate physical symptoms and conversely also make depression and depressive symptoms worsen. It is well documented that depression can impact overall cognitive function, which then negatively impacts the patient's ability to self-manage their medical conditions, including medication compliance, physician and specialty appointments, and the performance or their overall care plan, their ability to implement their overall care plan. I'm sure that many of the community health workers attending today can cite many examples of how depression impacts their patients. When depressed, patients can sometimes not follow through with diet and exercise regimens, which can lead to increased lethargy and a downward spiral effect of continued poor self-management and isolation. Depression is also associated with other negative behaviors such as tobacco use, smoking, alcohol, and substance abuse. I just want you to look at the statement from the World Health Organization World Health Survey about the impact of depression and chronic diseases or the impact of depression on chronic diseases and how these things impact the patient and our overall population. So we're going to jump in now to prevalence and cost. So it's important to consider that depression is a biological disease state in its own right. Can also result from other biological illnesses such as dysfunction of the thyroid and other central nervous system disorders that impact the neurobiological systems of our brain, such as Parkinson's disease, multiple sclerosis, and, of course, obviously hypothyroidism or thyroid disease. Depression can also be precipitated by situational events such as death, job loss, changes in family, and the effects of the disease burden of attempting to manage chronic conditions. So situational depression or depression can also be caused by the patient's inability or difficulty in coping with their overall disease burden. The good thing is that treatment is available for either biological or situational, endogenous or exogenous, as we say in the field. Endogenous meaning internal or biological depression, exogenous meaning depression caused by external factors. So biological or situational depression with or without chronic conditions can be treated. Medications, talk therapy, and other interventions have been proven to be successful in treating depression. So we're going to discuss several of those interventions and medications later in the presentation. So depression does increase a patient's overall risk of mortality and morbidity or increased impairment over time. Patients with depression have been shown to have poor prognosis and a more rapid progression of chronic illnesses, likely caused by the increased stress of dealing with the illness and the degradation of self-management skills. Strategies such as diet, exercise, medication adherence, positive thinking, and other pro-health coping patterns are often impacted by depression in patients who have chronic conditions. So overall, they just have a harder time coping with all of the medical conditions in their lives, including depression. Depression also has a demonstrated effect on blood glucose levels by a decreased glucose tolerance and increases in blood glucose. Andrea will be talking about the impact of depression and diabetes in a few minutes. So we'll talk a little bit more about that in depth. So looking at, I'm just going to show you these figures here. You can look at them. I highlighted one particular statistic that stuck out to me, that the prevalence of major depressive disorder in the U.S. was about 13.8 million in 2005 and about 15.4 in 2010. And that people 50 and older represented the fastest growing group of those with major depressive disorder or problems with depression. So again, multiple studies have shown that depression is associated with increased costs in every sort of cost component, as is noted here, and that includes primary care, pharmacy, emergency and urgent care, and inpatient and outpatient mental health utilization. And that's only about 10% due to mental health utilization that the utilization of mental health services is hopefully expected and encouraged. So when compared with usual care, so collaborative care intervention associated with trends for decreasing cost component. And Andrew's going to talk about collaborative care models at the end of toward the end of the presentation. So there's some promising collaborative care models that do reduce costs in treating patients with depression and chronic illnesses. So patients with comorbid depression and chronic illnesses have more physician visits. They tend to utilize ED more. There are more missed days from school, from work, and from other social commitments. An estimate of patients with major depression disorder in primary care was about 5 to 10%, and the rate of depression in patients with diabetes are estimated to be about 12 to 18%, and those with coronary heart disease about 15 to 23%. Looking at primary care setting, and I should have prefaced my last slide by saying looking at the primary care setting, depression may be missed by primary care physicians due to some symptoms that may overlap, inadequate time for physicians to accurately assess behavioral health conditions. Physicians may also elect to withhold treatment of depressive symptoms due to lack of knowledge and experience, and because of fears of overburdening the patient. They're afraid that they don't want to load another thing another issue onto the patient to deal with. There is also the risk of misdiagnosis because of the complex overlay of depressive symptoms and symptoms related to chronic conditions such as diabetes and heart disease. Screening tools such as PHQ-2 and 9 can only go so far in identifying patients who may have a depressive disorder. And we're going to talk about the PHQ-2 and 9 in a little bit, but those are just screening tools. So remember, when you're screening a patient for any condition, where there are evidence-based screening tools available. I'm thinking of depression and alcohol use or substance use. The screens only identify the possibility that the patient may have that condition. So again, more further, formal assessment or more time spent with the patient talking about their specific symptoms and how those symptoms may overlap with some of their chronic medical condition symptoms is important. So a referral to specialty mental health behavioral health services may be warranted in some cases. So in primary care setting, it makes complete sense that physicians view patients with depression as being more difficult to treat. It's the primary care physicians rate patients more difficult to treat, and that makes absolute sense. That makes absolute sense. Unfortunately, primary care has become the de facto mental health setting for many patients, especially those with Medicaid and Medicare, where it's harder to find specialty mental health services for those patients. Long waiting lists, some specialty mental health settings don't accept Medicare or Medicaid. So it does make that more difficult. So oftentimes the primary care setting does become the de facto mental health setting for a lot of patients. So primary care physicians have been forced to become mental health providers and will frequently manage their patients' medical and behavioral health conditions. I think that's a good thing. I think it's almost by default that they do that, but I think primary care patients have done primary care physicians, have done an incredible job of trying as best they can to manage patients' depressive symptoms in the primary care setting by prescribing SSRIs, SNRIs, and other psychiatric medications out of need. We see that a lot in rural settings. In some of the practices that we work with and some of our other task orders that in rural settings and urban too, that the primary care docs are almost forced to become mental health practitioners out of necessity because of the dearth of referral resources and ability for patients to get to those resources too. Oftentimes in rural health settings there may be, I know we worked with one practice in up near Traverse City, and for most of their patients it was a 30 to 45 minute ride to get to specialty mental health services to see a psychiatrist. The wait lists were very long. So a lot of the primary care physicians in that network were treating their patients for mental health disorders in the outpatient, or in the primary care setting. So as to be expected, these patients often schedule more primary care visits, but at the same time often cancel their appointments because of the debilitation that's caused by the burden of managing many chronic conditions. So I'm going to turn it over to Andrea now, and she's going to talk a little bit about how diabetes and coronary heart disease are impacted by depression and vice versa.
Thanks, Mark. So like you said, next we're going to look at the relationship between depression and chronic diseases, specifically diabetes and cardiovascular disease. So chronic conditions are consistently associated with an increased prevalence of depressive symptoms and disorders. So in some cases, depression appears to result from specific biologic effects on the chronic medical illness. Depression can significantly increase the overall burden of illness in patients with chronic medical conditions. And depression is 2 times as prevalent in persons with diabetes than those who are without. Managing diabetes can be stressful, and that could lead to symptoms of depression. Diabetes can cause complications and health problems that can worsen those symptoms. Depression can lead to poor lifestyle decisions, such as unhealthy eating, less exercise, smoking, and weight gain, and all of these are risk factors for diabetes. Depression affects the ability to perform tasks, communicate, and think clearly, and that can also interfere with the ability to successfully manage diabetes. Patients who do have comorbid mental health and medical conditions experience higher healthcare costs, and that much of the difference is attributable to the higher medical as opposed to the mental health expenditures. So total health expenditures for persons with diabetes and depression are 4.5 times more than for those who are without depression. So depression not only affects a person's behavior and brain, it also affects the entire body. Depression has been linked with several other crucial health problems, including diabetes. So dealing with more than 2 serious health problems at a time can be extremely difficult. So the proper treatment for depression is really, really important. Depression or major depressive disorder is one of the major serious mental illnesses, and depression directly interferes with the patient's daily routine and their life and could also decrease their quality of life. So like I said, the stresses of managing diabetes on a day-to-day level is real, and that can make people feel maybe sad or isolated. So depression and diabetes can easily spiral into this vicious cycle. So if a patient is depressed and lacks motivation, chances are they will find such tasks as regular blood sugar testing to be a little too difficult or too much for them to do. So it can be hard to keep up with, a good diet and to manage their blood sugar levels on a day-to-day basis. And of course that affects their diabetes, which could ultimately in turn again affect their depression, and again that's going to turn into that vicious cycle between the two. So despite the availability of measures that are in place to screen for depression, it's estimated that less than 25% of people with depression are diagnosed and treated. Only 35% of those who are diagnosed with depression have sought treatment within the past year. And research has revealed that both cognitive behavioral therapy and antidepressant medications are associated with decreased severity of depression, improved treatment adherence, and also improved glycemic control. So one important note here, though, is that SSRIs, such as Zoloft or Prozac, those could lead to weight gain, drug interactions with diabetes medication. So just wanted to point that out. Patients with cardiovascular disease are reported to have a higher risk, or about 1.6 times higher risk of developing depression than the general population. So patients with depression are also more likely to develop cardiovascular disease than those who are not, and this is independent of traditional risk factors. A study showed that patients who develop depression after an acute myocardial infarction, or AMI, have a 3.6 times increase in their mortality rate. Among patients with a recent AMI, are as many as 2/3 more likely to report depressive symptoms after that event. So cardiovascular disease and depression are linked in a number of ways. Unmanaged stress could lead to high blood pressure, arterial damage, irregular heart rhythms, and a weakened immune system. And for people who have heart disease, depression can increase the risk of an adverse cardiac event, such as a heart attack or blood clot. For people who do not have heart disease, depression can also increase the risk of a heart attack and development of coronary artery disease. So because of the potential impact on morbidity and mortality outcomes, screening for depression is highly recommended for patients who have recently had a cardiac event. So I'm going to turn it back over to Mark, and he's going to talk a little bit about screenings for depression that are available.
Okay, thank you, Andrea. So we're going to talk a little bit now, as Andrea said, about some interventions, and we'll start with screening for depression, which is a great thing for primary care physicians and some specialty physicians to do to identify patients that might be depressed. So there are 2 evidence-based tools for depression. There are many others, but the 2 that are frequently used are the PHQ-2, which is called Patient Health Questionnaire 2, which is 2 questions. And this is generally the first line or first step screen to be used. And it asks questions about the frequency of depressed mood and anhedonia, which is the loss of interest in normal activities or pleasurable things over the past 2 weeks. So 2 questions, Patient Health Questionnaire 2. And generally, if the patient answers yes to any of those questions, the secondary PHQ-9, Patient Health Questionnaire 9, would be 9 questions, that would go into a little more detail about the patient's sleep, energy, appetite, feelings about self. There is a 10th question asking how difficult the problems have been with the PHQ-9. So generally what will happen is PHQ-2 is given yes on any of the first two questions, PHQ-9, and I'm not going to get into scoring with this, but there are some scoring guidelines where, depending on the numerical score you get, there are some recommendations for interventions, and it also assists the tester in the level of severity of depression. Now, in order to arrive at a definitive diagnosis, it is recommended that a clinical interview be also included where you can assess degree of impairment and rule out other causes or symptoms. So again, screening tools they're good for screening, for identifying the possibility or to identify patients that require some more intervention or some more assessment, And oftentimes the PHQ-2 and 9 are very good at assessing patients or screening patients that do have depressive disorder, major depressive disorder, or to varying degrees. So they are both very accurate and reliable tools. So the PHQ-2 and 9 are a grade A best practice intervention by the U.S. Preventive Services Task Force. So they grade them on importance or the idea of it being an evidence-based, and there's a lot of scientific background and research to support that. So it is a grade A best practice intervention. It's widely accepted and adopted by most physician organizations, health plans. It is reimbursable under Medicare. It is recognized by Medicaid also, and most physician offices use the PHQ-2, PHQ-9. There are others. There's the Back Depression Inventory. There's the Edinburgh for postpartum depression, and there are some other screens for depression and anxiety mood disorders that are available, but the PHQ-2, PHQ-9 are essentially the gold standard. They also allow for an immediate review of a patient's mood and symptoms, and also longitudinal review. So the PHQ-9 can be given on subsequent visits with the patient to determine how their depression is improving or not, based upon the interventions, medications, or other interventions that are provided to the patient. PHQ-2 and 9 are in most electronic health records, so most EHRs have the PHQ-2 and PHQ-9. So now we're going to talk a little bit about antidepressants, as the slide indicates here, that there are the two SSRIs, and I'll explain SSRIs and SNRIs in just a second. But two antidepressants, often selective, have been found to be safe for patients with cardiovascular disease, and they're effective for moderate, severe, or recurrent depression. Research indicates that treatment soon after myocardial infarction appears safe and relatively inexpensive, and appears effective for post-MI depression, myocardial infarction. Patients with recurrent depression who has responded and tolerated well to another antidepressant may begin taking it after a myocardial infarction or a cardiac issue, unless it is now contraindicated and the physician is able to determine that. And use of anxiolytics, anti-anxiety medications such as Xanax, Klonopin, and Ativan do pose risks as first-line treatment for antidepressants, first-line treatment for depression, Xanax, Klonopin, and Ativan are benzodiazepines, and they increase fall risk. They're synergistic with other sedatives, opioids, and alcohol, and can lead to tolerance and dependence. So what I mean by synergistic is the fact that any sedative drug will be synergistic to another one, meaning that it will potentiate or increase the effect of both the drugs that are mixed together. So if you have a patient that's taking Xanax, that takes opioid medications. There can be increased respiratory depression. There can be increased fall risk because both those medications act synergistically on one another and make each other stronger. So obviously there are some patients that are treated with Xanax and Ativan or other benzodiazepines in addition to antidepressants, and that's certainly a decision that the treating physician or psychiatrist will make. But as a first-line treatment for depression, generally not a good choice. Okay, so what are the antidepressants? A couple of the major ones that we have available to us. There are selective serotonin uptake inhibitors, or SSRIs, and their clinical activity is in the brain to allow increased availability of the neurochemical serotonin at the synapse. So what it does is it allows the synapse to absorb. It allows more serotonin to be absorbed, thus increasing levels in the brain over time. And the trade names for some of the SSRIs are Prozac, and Zoloft. Then we also have selective serotonin norepinephrine uptake inhibitors, and norepinephrine is another neurochemical associated with mood. And the same thing these work in the same way. They allow more serotonin and norepinephrine to be absorbed at the cell level, the synapse level, and over time it will increase the levels of serotonin and norepinephrine in the brain. And some of the trade names for the SNRIs are Cymbalta, Celexa, Effexor, and a relatively new one, Presti. Both of these SNRIs, there are some side effects. There can be some side effects with these medications, nausea, some difficulty sleeping, and there may be some others that are specific to the patient, but generally these medications are well tolerated in patients, and the side effects do dissipate usually over 2 to 3 weeks or so. The effects of these medications often take a little longer to show some full effect. It generally takes sometimes up to 4 to 6 weeks to show significant improvement in patients in terms of depression, just because of the fact that you're dealing with the neurochemicals in the brain. And these things, oftentimes it takes a little longer for those to make the serotonin and the norepinephrine more available in the brain chemistry. So sometimes it just takes a little longer for that. So they're not. When you take an anxiolytic, you take a Xanax or a Ativan or one of those medicines, the effects of those are almost immediate. The antidepressants take a little longer to work, but generally are well tolerated. Cognitive behavioral therapy. I know Andrea had mentioned that before. And talked a little bit about CBT. And CBT, or cognitive behavioral therapy, is a talk therapy modality that has become increasingly popular in the last 10 to 15 years. Cognitive behavioral therapy is usually well received by most patients and is the type of talk therapy most likely to be associated with fewer numbers of counseling sessions than, say, psychoanalytic or other forms of talk therapy. Oftentimes, cognitive behavioral therapy can be accomplished. Good progress in cognitive behavioral therapy can be seen in 6 to 10, maybe up to 15 sessions, as opposed to months or years with other types of talk therapy. Cognitive behavioral therapy works by helping the patient identify distorted or unrealistic thought patterns and beliefs. The patients are then assisted in creating new, more realistic and adaptive ways of viewing and acting in situations that cause them discomfort or distress or cause them to feel sad. At least 12 to 16 sessions over 12 weeks have been shown to achieve remission in moderate to severe depression. So there are studies that show that cognitive behavioral therapy does work for patients with moderate to severe depression. So I think that as a past therapist and who's used cognitive behavioral therapy, I've seen patients improve significantly by just helping them look at the distorted or unrealistic thoughts or beliefs they may have and getting them to look at things in a more realistic way, and then shaping their behavior and their responses to those identified situations they used to see as distorted and now are seen more clearly. It does show some significant results, and it's generally very cost effective, and I think patients respond very well to it because, I think in my experience as a therapist, some patients are averse to the idea of, they come in and talk about my childhood and go into all this, past drama. A lot of times if you look at a specific solution-oriented focus for a patient, I think some of them respond very well. That's not to say that everybody responds well with some patients. I think their issues and their issues are probably deeper set and require a little more investigation, but a lot of patients do respond well to cognitive behavioral therapy. And so as patients develop new adaptive ways of coping and that are reinforced by a therapist, it leads them to increased feelings of self-worth and improved mood. So now I'm going to turn it over to Andrea, and she's going to talk a little bit about some other interventions for treating depression. Andrea.
So I'm going to specifically talk about exercise. Research has shown that exercise is also an effective treatment for depression, although it may need to be combined with antidepressants for patients who have severe depression. If a patient is prescribed exercise, it needs to be very individualized based on their cardiac status and what their current exercise capacity is. So researchers suggest that if a patient participates in about 3 to 5 exercise sessions per week for about 45 to 50 minutes per session, they should be achieving a heart rate of about 50 to 85% of their max, and that would be helpful in treating their overall depression. Data regarding the positive mood effects of exercise involvement, independent fitness gains, and that suggests that the focus should be on the frequency of exercise rather than the duration or the intensity of the exercise until the behavior has been well established and the patient has been doing this on a continual basis. So cardiac rehabilitation programs are also an essential component of recovery for patients who have had a cardiac event, and that could reduce the emotional, psychosocial, and physical issues that affect an individual after experiencing that life-threatening event. Some key elements of these programs are exercise, education on lifestyle changes, and also the patients can be provided with professional support that's available to them. So in particular, those who participate in group exercises are a physical and psychosocial activity, and that could significantly help prevent depression and also assist in reducing the mortality rates for those patients. Following a major cardiac event, cardiac rehab could be associated with both reductions in depressive symptoms and also that associated excess mortality. So only mild improvements in their fitness level could be needed, but it can make a fast improvement in their overall health in relation to depression and also their mortality rate. And as Mark mentioned, I'm going to talk about collaborative care models. So collaborative care is a specific type of integrated care developed at the University of Washington, and it treats common mental health conditions such as depression and anxiety that could require systematic follow-up due to their persistent nature. So in this model, trained primary care providers and embedded behavioral health professionals provide evidence-based medication or psychosocial treatment, and those are going to be supported by regular psychiatric case consultations and also treatment adjustment for patients who are not improving as expected. So implementing the collaborative care model requires a new way of thinking about how mental health is delivered, and it usually requires a significant and oftentimes challenging change in the clinical practice. So there is a lot of culture shift that occurs in the new collaborative care model. An example of a collaborative care model is the care of mental, physical, and substance use syndrome, or COMPASS model. So this model was a CMMI grant testing of an integrated care approach in primary care clinics, and that was specifically for patients with depression and diabetes, heart disease, or risky substance use, and that example met the triple aim for improved patient experience, better outcomes, and lower costs. So some key components of the COMPASS model include a care coordinator, which usually was a registered nurse, and the registered nurse would meet with the patient weekly to monitor their condition and also provide support and some active follow-up. There was also a consulting psychiatrist and a primary care provider who would review any problem cases that the patient might have had with the care coordinator on a weekly basis, and then also providing treatment recommendations to that patient's primary care physician. And in total, there was also a computerized registry that held an ongoing data analysis and quality improvement options to help manage that patient's care. So that was just an example, one example of a collaborative care model that was successful. So just in summary, to give you an overview of everything we went over today, we talked about the importance of recognizing and addressing depression in patients with chronic disease. We also talked about the prevalence of depression in diabetes, cardiac disease, and other chronic conditions, and also looked at the overall burden and cost of healthcare in patients with those chronic diseases and depression, and also looked at behavioral and pharmacological interventions that can assist in treating depression.
Well, thank you, Andrea, and thanks to everybody today who has been on the webinar. Continuing education. So we're going to be offering nursing, social work, and general participants continuing education, 1 credit hour. There is 1 evaluation form for all participants, nurses, social workers, and general participants. If you're requesting more than 1 certificate, you only need to fill out the evaluation form once, but make sure you check all the certificates you wish to receive. Now, all online evaluations must be completed in the designated time frame, so what's going to happen is you're going to get an email. The email that you use to register for the event, you will get an email. Now, if you were a multiple viewer in a room, there's some of you that are watching this in a room together, and 1 person registered, you can email your address to cehelpdesk@mpro.org. That's cehelpdesk@mpro.org, and it's on the screen there. And just let us know that you've used the webinar, Depression and Chronic Conditions. You're a social worker or a nursing, or you want a general certificate, and we will send the evaluation email to you. So the online evaluation will end on September 5th. It should go out a day or so, and we'll email you your certificate within 4 to 6 weeks. So once the survey is closed, it cannot reopen. So you have to do this by September 5th. So it gives you plenty enough time to do that. So if you have any questions during this process, please contact the MPRO CE Help Desk at cehelpdesk@mpro.org and ask for assistance. Or again, if you're a multiple viewer and you didn't register for the webinar, you can go ahead and just let us know that you did, and our staff Toria will send you out an email with the evaluation. Okay? So I'm going to open it up for questions if anyone has any. Operator, would you please let our viewers know how they can ask questions?
Certainly. Ladies and gentlemen, at this time, if you would like to ask a question, please press the number 1 key. Once again, if you would like to ask a question, please press the number 1 key.
Or you can put them in chat if you'd like to.
Our first question comes from Rachel Mesker with Fairview Physicians. Please go ahead.
Oh, I put my question in chat to the host, but what interventions have you guys used with those patients that cancel or no-show to appointments? What interventions as far as engagement have you found success with?
that's a good question. I'm going to open that up to people listening on the webinar, because at MiCHWA, we're a quality improvement organization, so generally we work with physician offices that treat patients with depression. And I know anecdotally some of the things they've told us to do would be obviously multiple phone calls, attempting to contact them by either email or phone to secure a return appointment. But that is a difficult problem. And I would encourage anyone listening who has used or has developed or used an intervention that is successful in addressing this to call in or put it in chat.
Our next question comes from Letitia Turner from Spectrum Health. Please go ahead.
That was one of the questions. I had a concern with the same thing with doing home visits, and we're knowing that when a person has been clinically diagnosed with depression, there's a higher rate of no-shows. And I think one good thing that we do is, making those multiple phone calls or doing extra drive-bys, sending postcards. But the other question was, would all of the viewers and listeners be able to get an email of everything that was discussed?
You can get the slides. And actually, this will be on our YouTube channel too. Okay. You can actually view this in a week or so. It'll be posted on our YouTube channel. But the slides, there's a link to the slides. I think it was Letitia. There's a link to the slides in the chat box.
Okay. Thank you.
Yeah, thank you for your response to the question. I think you're right. Just more concentrated attempts to contact the patient, and sort of if there's care management in the primary care practice, that always helps because oftentimes office staff, physicians, and nurses don't have time to make the phone calls. But if there's any sort of care management, social worker or care coordinator to just do the full court press on a patient to try to keep them, tightly engaged in the treatment you're providing is helpful.
Our next question comes from Joel Schaffner with Priority Health. Please go ahead.
Two things. In response to the issue of no-shows, I work with the homeless Medicaid population and is developing a relationship with the patient so that they trust the healthcare system that they're being drawn into has proven to be very effective. But my question is there a difference in depression with diabetes between type 1 and type 2?
In my research, I did not find a difference between type 1 and type 2. This was specifically geared towards type 2 diabetes with the information that I presented.
Okay.
And thanks for the suggestion on engagement of patients by developing the relationship with them and making them feel more safe and secure, comfortable with the healthcare organization they're working with.
Our next question comes from Angie Banner from Ingham County. Please go ahead.
Hi, can everyone hear me?
Yes.
Hi. I actually don't have a question. I'm piggybacking off the last person's comment. I am a community health worker that works for the health department here in Ingham County. I work for a program where I am the community health worker that connects people. So we work with people who are Medicaid eligible, and we're helping them overcome those barriers. So missing the appointments, maybe not just making a relationship, maybe they don't have transportation, maybe they don't understand that their Medicaid plan provides that, and working through that process with them so that they can get the transportation they need back and forth to their appointments so that they're not missing it. Many of them say, well, I have family that can take me, and when it comes down to time for the appointment, of course, they all have lives of their own and aren't able to. So getting them connected to resources in the community to help support them on the outside is really helpful, and making sure they understand that their insurance, at least in our county, the plans we have do provide transportation back and forth to those mental health appointments and making sure they understand how to use it and navigate through that process.
Thank you so much. I think that's the beauty part about community health workers is they have that connection with the patient and have the ability to access all the different resources and know a lot about the health plans that they're working with. So, Andrea and I were very honored to work with Priscilla to present this webinar today. And it's so nice to hear from a community health worker. We really appreciate it.
Thank you.
Our next question comes from Kristen Erdman with Upper Great Lakes Family Healthcare. Please go ahead.
Hi, yeah, I actually just wanted to also piggyback on stuff that Andy was saying. I'm a community health worker here at Upper Great Lakes Family Healthcare, and we also do integration here as well. So when our patients come in, we look at the schedule ahead of time and notice, our patients coming in with depression or anxiety, and they have those comorbidities of diabetes or hypertension, and we'll go in and, see where the patient's at, see if they're willing to learn any skills to work with depression or work with anxiety. And then we also have behavioral health. So at that point, we can even refer them to behavioral health. That's right in our office as well.
Oh, that's great. I love the idea of sort of patient-facing self-management materials and tools. I know we had one practice up in East Jordan in Michigan developed just a booklet that had a lot of self-management and coping skills in like just a regular three-ring folder that they gave out to their patients to help them self-manage and cope with depression. Just a lot of basic stuff, but they found that it was very helpful to their patients. So thank you. And again, another community health worker, thank you for being here.
Our next question comes from Kayla Font with Medica. Please go ahead.
Hi, I'm kind of piggybacking off of everyone else's ideas of how to get, the no-shows, and we serve at Medica the program that I work in. I'm a care coordinator, and we work with the Medicaid population, and one of the things, again, is just that trust relationship. Having multiple phone calls with some of our members who are at higher risk for hospitalizations or mental health, and we have a mental health behavior program as well. But I think one of the other things that we get to do with our patients is that once we've developed that trust is going to their primary care physician appointments if they allow us or welcome us to go. And I think part of that is just that, relationship building, trust, working with that member. I maybe have been in the home. I know the environment. And so being able to sit with that member while they're visiting with their primary care physician and talking through some of that stuff has been very beneficial for our members as well.
Very good. Thank you so much. And that's the beauty of community health workers. You guys take that connection with the patient, that extra step in developing that very, very personal relationship and the ability to accompany them to, if they allow it, to primary care physicians and other specialty appointments. I think that's amazing.
Once again, ladies and gentlemen, if you would like to ask a question or make a comment, please press the number 1 key.
First of all, let me thank all those who piggybacked on the initial question on strategies for addressing no-shows and missed appointments. I really appreciate those of you that called in with your experiences with that, and that's exactly what we were hoping for, that we could get some real-life experience from some community health workers who are on the front lines of helping patients get better.
We have no further questions at this time.
Okay, so I want to thank everybody for attending today. I hope it met your expectations, and please, as you complete the evaluation, we appreciate you doing that too. Again, we do have social work and nursing continuing education, plus a general certificate of participation for anybody else that is interested in that. I know community health workers like to keep a portfolio of things that they've attended, learning sessions, and I know that's helpful. And so please complete the online evaluation. Again, if you were a part of a multiple viewing group, on the screen right now is the CE Help Desk line. and or the email address for the CE Help Desk. Let us know that you viewed it. If you didn't register yourself, and what discipline that you're looking for, and Toria will send you out a link to the evaluation to get your certificate, okay? And if you could just take a couple minutes to complete the online evaluation, it'll just take a couple minutes for you to do that. We greatly appreciate that. And thank you, Andrea and I both thank you for being here, and thank you for your questions, and it was an honor for us to present to you today. Thank you.
Thank you, ladies and gentlemen. This concludes your call. You may disconnect at this time.